Hey guys, Chelsea and Gina here. I am super stoked to hear from Gina. She has got a wealth of knowledge in nursing, forensic nursing, emergency nursing, all the things that I have very little exposure to. So my thing is knowledge is power, and I'm super excited to learn from you and what knowledge you have behind you. So welcome, Gina. Thank you for your time.
Oh, thank you. I'm happy to be here.
So guys, just so you know, Gina got held up at work, and so we are going live a little early. Apologize for anybody that is inconvenienced by that. Thankfully, it's recorded. But Gina's in her car, and we're just making it work because she's an ER nurse, and that's what you do. You roll with it. So we are excited to learn from you. Just introduce yourself briefly, and we'll get started in all the nuts and bolts of this conversation.
Oh, awesome. Well, I'm Gina Carbino. First, I'm an ER nurse. I've been an ER nurse for about 20 years, and about 10 years ago, maybe 12 now actually, I got into specifically forensics, and I worked as a statewide forensic nurse coordinator for a few years, and now I'm back home in my small town in upstate New York, and I work as the clinical education manager of a pretty busy and acute ER as well as a SANE nurse.
That's amazing. I hope we get a little bit of time to kind of cover it broad spectrum before we get into the gunshot wound patients. But just as an icebreaker, tell us your funniest nursing story.
Oh, well, I'm an ER nurse, so there's a lot of those. The funniest nursing story is probably a patient comes in and I'm in the back. I'm more of a senior nurse and I'm precepting a newer nurse to the ER. She was actually just a newer nurse in general. And she brings somebody back from triage. It puts them in a wheelchair, runs them back to our trauma room because they're blue. And blue means like, right, we need to do something right off on this patient. And I look at the patient and I'm not getting worked up and I'm like, something's not matching here. She's talking in full sentences. She's not working to breathe. She's not tachypnic. What's going on with this lady? I hook her up to the monitor. I do all the things that I would do normally, and everything, all of her vitals, stone cold normal. I'm like, I take an alcohol swab. I take it on her hands, and the blue is washing off. So this woman had died herself and came into the ER and said she was short of breath.
Oh my, that is gold. That is like key manipulation right there.
Yeah, so we get all kinds of patients in the ER, that's for sure.
That is seriously insane. That is so funny. Okay, so when did you realize you had a passion for forensic nursing in general?
I've always thought forensics was cool. Between like serial killers and, just the collection of forensic evidence, like crime movies and crime shows. I mean, they're everywhere now, but even back in the day, like, Quincy Adams or A Murder, She Wrote, that's super aging me, but I've always been fascinated with the kind of the whodunits, and that's what's great about emergency nursing and specifically forensic nursing is you get to be part of that world.
For sure. That sounds, I love that kind of stuff, but I don't really think I understand the full spectrum of forensic nursing as a whole. Do you want to just touch on just a little bit about all of it as a whole?
Yeah, absolutely. So forensic nursing has a national professional association, and that's called International Association of Forensic Nurses. There's also another national professional association that just started up more recently, and that's the Academy of Forensic Nursing.
Okay.
So either one of them are great resources to find more about forensic nursing, but forensic nursing is an umbrella term that covers a lot of different genres of nursing. So it could be corrections nursing, so the nurses that work in prisons and with law enforcement officers, that's considered under the umbrella of forensic nursing. Okay. Every ER nurse, it has a little bit of forensic nurse in them. Think about the sexual assault patients that come in, human trafficking, and then sadly, patients of interpersonal violence or domestic violence, and then even more sad, elder abuse and child abuse. So all of that, the documentation, the assessments, all of that is forensic nursing. We also have legal nurse consulting. That is underneath the umbrella of forensic nursing, as well as specifically SANE nurses, and that name is trending. We're moving away from SANE nurses to SAFE nurses, sexual assault forensic examiners. So a lot of states the national push is to change that nomenclature to SAFE. As well as coroners or forensic nurse death investigators. So there is South Carolina is home to a large portion of forensic nurse death investigators.
All right. Yeah, I didn't realize. I mean, I knew it was an umbrella term, but I didn't realize all those niches fit into that. That's really interesting. So what have you had experience in personally?
So, well, I've worked in the ER for about 25 years. So I have dealt with human trafficking, domestic violence, elder abuse, traumas, person-on-person violence, stabbings, gunshot wounds, strangulations. I can't remember if I said elder and child abuse already, but anything that would come in the doors to the ED. And I got really interested in that and making sure, because there's limited knowledge on maintaining chain of custody, how to identify these wounds, how to collect evidence properly. So I became a SANE nurse. So I went from being an ER nurse, I went and took the 40-hour didactic or classroom training for SANE. And then I did 16 hours one-on-one with another SANE nurse and spent about 300 hours watching expert testimony. I went to an OBGYN office and did pelvic exams for 3 days straight. So I just kind of gained all that knowledge. I spent some time with victim advocacy agencies, and then I was a SANE nurse in the ED for quite a few years. From there, I ended up joining and becoming a board of directors for my local victims advocacy center.
Oh, wow.
So how it's set up federally is each region has a federal and state-funded victim advocacy center. So no matter where you live in the United States, there's a place where you can call if a victim presents with interpersonal violence or sexual assault, and a victim advocate will come respond to the hospital to help that patient not only while they're in the hospital, but also afterwards, going to court. What does that mean? Being a support person for that person. So I served as a victim's advocate for the past 15 years, and then I was also a board of directors for 5 years for the Victims Advocacy Agency. From there, I ended up being the statewide forensic nurse coordinator of South Carolina. And what that entitled is going around and improving care and services and resources to not only the community of South Carolina, but also the hospitals and the nurses who were caring for those patients, both in sexual assault and human trafficking, as well as any person-on-person crime.
Wow. That's a lot to take in, and it's such a heavy, I feel like such a heavy emotional weight in that role.
Yes.
Yeah.
Yes, it can be.
Yeah. So
one of the defining moments when you're to play off your heavy emotional burden. This is probably one of the most. That was definitely one of the most intense jobs I had. But when it really hit home to me was I was always on call. I was a nurse, an ER nurse, called me at 3 a.m. and said, "Gina, I don't know what to do. I have a young boy here, 8 years old, and he's in my ER, and he's being discharged home because there's nothing. We fixed him up medically, but I don't feel safe discharging him home. What do I do?" So what had happened is he was in a detention center, and one of the people caring for him was putting fishing lures in his urethra and had tore his urethra open. They repaired it in the emergency department and then was discharged the child home. But she didn't feel safe sending that child home back to the detention center where he was. So then it gets into a jurisdiction issue, like what jurisdiction did this crime occur in? That's who the law enforcement should respond to the hospital, but it was the sheriff's jurisdiction, and it was a holiday weekend, so nobody was on call. So this poor child got lost in the mix of it being a holiday weekend and lack of resources for this vulnerable population. So there's definitely, that took a toll on me for a long time, because it doesn't matter where you live, there's a lack of resources for that vulnerable population.
Yeah, for sure. I have the hardest part of working in the PICU is those non-accidental traumas. And I've only cared for 2 gunshot wound victims, but both of them were not fresh in the moment. So that's just so heavy. That's honestly one of the reasons why I left the PICU. I just couldn't handle it anymore. I need to step away. So you post some amazing things in our Facebook group, and some of your responses to one of our members' posts about gunshot wounds was just mind-blowing. And a lot of us had tons of questions for you, and that's why you're here today, and super excited that you volunteered to share your wealth of knowledge. But if you could just share with us the most important nursing aspect for us to know how to appropriately care for these patients, maybe even present a scenario and maybe the do's and don'ts of us as nurses, what do we do?
So the easiest thing that we miss, or what the biggest thing that we miss, is the easiest thing we can do, and that's document and identify any wounds. Okay. So some of the research that's out saying that in a trauma setting, as a gunshot wound, nurses and even physicians are missing about 33% of wounds. And I don't believe we're missing them. I believe we're just not documenting them. And we all know if it didn't document, it didn't happen. So documentation is huge. The other thing that we can do, that you can do in any shop, you don't have to have this fancy forensic equipment. You can get paper bags at Walmart. That's super cheap. You can ask your director to pick them up. You can pick them up yourself. It's $2 or $3. Yeah. So being able to maintain chain of custody can be as easy as just picking up paper bags. If you have an article of clothing that's wet, you can put it in a patient belonging bag. We all have those. Those are usually plastic to keep the moisture contained, and then put it in a paper bag. When you hand it off to law enforcement, just say, hey, I have a wet, bloody shirt in there. I just wanted to make sure you have it. I've maintained chain of custody, but it needs to get dried at the closest law enforcement facility, and they can do that. It might be a ways away, so the officer might be traveling maybe an hour or two to the state capitol crime lab, but there's a setup for them to do that. As emergency nurses or SANE nurses, we don't have that capability in our hospital. So it might be just as easy as just letting the law enforcement officer know what you have. So for example, if you have a 22-year-old man, I'm going to actually run you through a scenario that happened to me. Awesome. I'm walking out of a very rural ED that I picked up per diem shift at. Okay. I'm walking out. This guy gets wheeled in by somebody into the triage. I'm walking out through the triage waiting room to my car. This guy comes wheeling in and gets pushed towards me in a wheelchair, and the guy who's pushing him runs out of the building. So I look at him. He looks okay. Then I look down at his legs, because looking at his face, as an ER nurse, I'm immediately assessing him. What does his color look like? What is his mentation? Is he making eye contact with me? That all seems fine. I look down, and he's holding his belly, and I can see blood oozing out. I immediately knew it was a gunshot wound from the setup, that some guy dropped him off and was exiting the building quickly. And that's a lot of gunshot wound victims. They might come in, either self-drive themselves, they might get dropped off in the front of the ER, or a lot of times they get dropped off in the ambulance bay right outside the ambulance door. So these are patients that we really want to keep a high alert for. Same thing with stabbing victims, and also toxicology cases like overdoses. They present in a lot of similar ways. So I brought him back, and the first thing we do is when we get him back, and medical attention, and it takes priority over forensic collection of forensic evidence. Of course, we're going to save his life before we worry about maintaining chain of custody. We got him back to the room. We hooked him up to the monitor. His vitals were okay. He was starting to get a little shocky. His blood pressure was low. He was a little bit tachy, but nothing that we needed to immediately volume resuscitate him. So we cut off his clothes, and when cutting off his clothes, if it's a stabbing, if it's a gunshot wound, any of those things, we don't want to cut through where the hole is. We want to cut around that. Each item that we took off him, you want to put gloves on, bag it, and then seal it, and then put new gloves on, and then take another article of clothing and put it in another bag. And can anybody guess why we do that?
Contamination?
Yeah, exactly. That's exactly right. So if there was multiple perps or multiple assailants, you don't want to cross-contaminate between articles of clothing. So it's a great way to narrow something down and corroborate that victim's story. So you want to make sure that you're bagging those items individually. And there's certain things, and I think I posted on our group about bullet wipes. It's the lubrication that's left when the bullet goes through the clothing into the person's body. It wipes off the lubrication off the bullet, and that lubrication comes from the firearm barrel. And so that can help identify or link that bullet to a specific firearm. So if there's absolutely no other evidence that can tie what this victim's saying, that can actually help corroborate and put the bad guy away. So it's really important that we cut around that bullet hole and we get that sealed up in a paper bag, and we maintain chain of custody. The other thing is, make sure you're maintaining chain of custody. Make sure you don't leave the clothing and go about your business, which that can be really hard if we don't have services set up for that in the emergency department you work in. An easy way to do that is you go to a conference or your victims advocacy agencies, those little tiny book bags that are just, they're just drawstring book bags you can shove stuff in. They are almost pennies. Throw everything in there and put it on your bag, put it on your back, and you can walk around the ER and do your business, and you've never left the stuff. You've never broke chain of custody. So that's an easy way for absolutely anybody to maintain chain of custody, because law enforcement can't always show up immediately. So it might be an hour or two later. And if you don't have a big fancy shop, you might not have somewhere to put this stuff.
Yeah.
So to the patient who's sitting in our ER, we've cut off his clothing. We have a bullet wound. We have two bullet wounds, right? We have an entrance and an exit wound. We might have multiple bullet wounds. Without extra forensic and ballistics training, all we're doing is identifying wounds. We're either numbering them or we're using an alphabetic system. I like numbering on myself. That's my preference. But there's no right or wrong as long as you just use one system and continue with it. The best thing to do is do a head-to-body assessment, right? Especially in trauma or gunshot wounds, that's highly emotional. It's exciting. You don't want to miss anything. So do a head-to-toe assessment and just document the wounds in numeric order. On top of that, what you can do is you can take photographs. That's the best thing ever, because as we're caring for that victim, we're going to mess things up and wash things and move things around. If we can get somebody in there to quickly take pictures around us, that preserves the evidence. And we can look back at those. Yes, ma'am?
Question. So we have students that are watching as well. I just want to make sure we're clarifying when we're documenting on the wounds, 1, 2, 3, 4, 5, we never talk about this one is an entrance and this one is an exit. Simply that this is, how would you describe this bullet hole? How would you describe it?
I would describe it by, this is bullet 1. It is located in the second intercostal space, mid-clavicular. I would get a tape measure out. Almost every hospital has some type of paper tape measure, and I would measure it length and width. Before the patient's gone to CT, I wouldn't be doing the depth of the wound, just the length and the width, and I would describe it to the best of my ability. A cherry red circumferential appearance, or the wound is bloody. So it doesn't even have to be fancy. Just explain it as you would any other wound. And yes, absolutely, without any additional training, you're just numbering, identifying the location and the measurement and the appearance around it.
Okay,
so
and then
would not identify. Oh, go ahead.
No, go ahead. You would not. Go ahead.
you would not identify entrance or exit, because without that training, you don't know. It can be tricky, even for an experienced ballistics nurse.
Great points there. And then you talked about taking pictures. Now, we wouldn't want said student or new nurse taking out their iPhone to photograph these wounds.
Correct.
Who is going to be taking these pictures, and do we need to submit some sort of order or consult? How do we go about getting someone to take pictures?
So that's going to be unique to the department, the emergency department you live in or work in. The oldest, cheapest way to do that is Polaroids. And then the Polaroids become part of, and back in the day, that's how we did it. And that still works today if you don't have a fancy camera system. Yeah. So Polaroids then become part of the patient's chart, and they're protected just like any of the patient information. Yeah. So even in, depending on the state that you live in, depends on if gunshot wounds are one of your mandatory reporting laws. So there's a lot that goes into it that we can't go into today. That's a whole talk on itself, maintaining the difference between HIPAA and chain of custody. An easy way to know it is chain of custody is a little bit different and a little bit more strict, as in chain of custody, somebody has to have a court order to get that information. Also, then there's mandatory reporting laws, and those are unique to the state that you live in. So New York is different than South Carolina, different than Ohio. So it depends on what your mandated reporting laws are, on what you can release to law enforcement.
And you refer to your board of nursing for your state to distinguish what is mandatory reporting and what's not based on your state.
So,
okay.
Yes and no. So state legislation is actually what determines mandated reporting laws. Most board of nursing in the state that you live in have it somewhere on your website, but they don't determine it. That's actually, it's your state legislation that determines that.
Okay, but we can find it at the board of nursing.
In most states, yes, you can.
Good. Perfect. Knowing where you can find your resources is more than half the battle, right?
Yes, and I actually have a great website that is from the Victims' Rights Law Center that goes over all mandated reporting laws, and it's digital. So whatever state you are, you can just click the link and it gives you the laws and a link to your state legislation. So I'll post that in our group afterwards.
Oh, good. I'm so glad. Humari says, I know I'm a home health care nurse and you need a patient's signature for photos of wounds. Is that necessary in the hospital emergency room setting?
It depends on your organizational practices. So most organizations and most states, yes, you do need consent, except for the cases of minors where emergency consent can be done if the provider or the forensic nurse suspects abuse. Okay,
good to know. Okay. Tina asks, what types of care are you providing to this patient in terms of forensics? Collection of evidence, treatment, emotional support? What exactly are you providing for this patient?
And I think regardless of what kind of nurse you are, the answer is holistic care, right? Yeah. We're going to take care of their medical needs, and also their psychosocial needs. So you might be calling in that victim advocate to come sit with the patient and describe to them what's happening and help them through that. And then also post-discharge. But then you're also, as a forensic nurse, going to collect forensic evidence. And that can be as little as documenting what you see versus collecting the clothing or the bullet and maintaining chain of custody and handing that over to law enforcement. And then 3 months, maybe even 3 to 4 years later, testifying as a fact witness.
So your documentation is absolutely key in all of nursing, really. But in these situations, you don't remember bullet 1, 2, 3, 4. You just don't. And so your documentation has to be remarkable, right? That's all you have to go by.
Absolutely. It's so important in gunshot wounds, and where it's even more important is domestic violence and interpersonal violence cases. So in most cases, if you look at people who were a homicide as a result of domestic violence or interpersonal violence, most of those cases, around 80% of those cases, presented somewhere previously for wounds or injuries related to that domestic violence. The other thing is when that victim goes to court to get a court order or to put the bad guy away, all they usually have, all they rely on in that courtroom is their version of the story and whatever was documented by nursing or providers, of course. So
Wow.
in those cases, those victim-on-victim crimes, documentation is everything.
Jeez, that's so crazy to think that, our documentation on paper it really is a fact of, is the victim or is the criminal caught or not, right? That's crazy. Okay, so Tina asked, what are the most critical time-sensitive things to look for? Is there anything that's, this is just me thinking off the top of my head, like a rape victim. Is there anything that's super time-sensitive that needs to be handled in some sort of sequential order?
So the thing that needs to be handled as quickly as possible is STI and HIV prophylaxis. There's a time frame specifically on HIV prophylaxis. There's a time frame. If we give HIV prophylaxis and medications within that 72-hour time frame, there is up to a 98% efficiency rate with those, or efficacy rate on that. That's almost 100%. So if we can give that victim meds right off, we can pretty much say that this victim is not going to contract HIV. So there is a time frame. After that, we don't even give the medications because they're not effective. So definitely STI and HIV medications, I would say, are the most important thing to get on board and to get on board quickly. And also Plan B or pregnancy prevention medications.
Okay.
The other thing that we want to get on board quickly is the psychosocial aspect, is making sure that they're hooked up with a victim advocacy center. Getting the patient's story or their memory of what happened, honestly, is not the most important thing. So in somebody that's had, and we're learning more and more about trauma and the effects of trauma on the brain. And generally what we want that victim after a traumatic event to have two cycles of REM. So 2 nights sleep to sort of put everything where it's supposed to be. So I think of like after somebody has a trauma, a snow globe that gets shook up and everything is everywhere. And it takes about 2 cycles of REM to sort of settle everything. And that's always best to get their history at that time, a full history of the event at that time.
Wow, that's incredible. I had no idea. I'm interested to research that. That's really interesting. So in terms of gunshot wounds, is there anything critical or time sensitive in those sort of patients?
Well, in gunshot wounds patients, what's critical is those are usually if it's the core or the thoracic or even abdominal cavity, we've got some big ticket items in there, right? Heart, aorta, liver, spleen. So in a time sensitive manner, it's time sensitive to get that patient to the OR as quickly as possible. And that still falls under the golden hour of trauma. So we want to get them from the injury into the OR in about 60 minutes or less. What we don't want to do is, and sometimes if we have something that's in the abdomen, we'll bypass radiology and get them right to the OR because we know that this is something serious. Yeah. The other thing to think about with ammunition or fire or gunshot wound injuries is the type of ammunition that was used. So we have so much ammunition, and they all do different things. Mm-hmm. Do we have a full metal jacket that has, enters the body, takes its velocity and power with it, and exits the body? Or do we have a bullet that explodes upon impact? And so if you think about which one is going to do more damage, it's going to be a bullet that frags, or a frag bullet that explodes upon impact. So you don't even know where those pieces are, right? You might have an entrance and exit wound in your abdomen, but you have shrapnel that made it to your heart that's caused a pericardiocentesis, or a cardiac tamponade rather, that requires a pericardiocentesis.
Mm. Yeah. And I mean, as an ER nurse, would I know that just by looking at it, or would you need more forensic training in order to be able to pinpoint that?
So you would definitely, I think as an ER nurse or a trauma nurses and emergency nurses are trained to handle that type of injury. What they're not trained is the additional training in collection of forensic evidence. So, for example, if I have a gunshot wound and the doctor can visualize the bullet, we would want to remove that bullet. When doing so, we don't want to use just plain like hemostats to grab that bullet out. What we want to do is we want to put suture booties on the hemostats. Mm-hmm. And regardless, that might sound fancy, but any shop has them in their OR. So you would just call down to the OR and get a couple sets of suture booties to keep in maybe like a forensic cart you have, or even in your trauma cart if you may. I love binders and I love carts. I think they keep things organized.
Yeah.
And what those are they're just little cute, tiny little rubber booties that sit on the end of your hemostat. So when you grab that bullet, it doesn't mar the ballistics of that bullet, so we can corroborate that bullet to the firearm that was used. Mm-hmm. The other thing is, you don't want to put it into a metal petri dish or a metal storage container. You want to put it, the best thing, urine cups, right? They're plastic. I can screw them on. I can put a sticker over the top and maintain chain of custody. And there isn't an ER on the planet that doesn't have a urine cup.
So smart. And would you want to use a different pair of booties for each bullet?
Yes. However, that would be best practice. However, it's not, if it's a life-threatening injury, remember, the care of the patient is going to supersede the collection of forensics, so they're generally not switched. If it's something that we have time for, then yes, we want to switch everything as possible.
Okay. Makes sense, of course. Okay.
And you think about that, right? If you have a patient that is a victim of a gunshot wound, there might have been multiple firearms used.
Right. That's what was my thought as you were describing removing the bullet. I could just picture having more than one firearm, and you're contaminating, going from one wound to the next. But yeah, that's, of course, patient safety is number one. So Frida asked, what do SANE nurses do this type of forensic nursing as well, which you already answered, but her question's twofold. Do bedside nurses have special training for this? Like, how do you become a SANE nurse or a forensic nurse? You talked about a little bit of the forensic training. What about SANE? Does that fall into that? Or sorry, you talked about SANE training. What about forensic training?
So during your 40-hour SANE or SAFE training that's offered in multiple states, you can go on the IAFN website, International Association of Forensic Nurses, and find training that is near you. During that 40-hour didactic training, you do get training on a widespread umbrella of forensic nursing. So I think that if anybody's interested in forensics, that's a great way or a gateway into forensic nursing. There's now different colleges that have forensic nursing programs. My predecessor before me, that was in the role before me of my statewide forensic nurse coordinator job, she moved to Alabama and runs the forensic nursing program at the University of Alabama. So there's different, you can specialize in forensics in your college degree. And there's also various workshops. If you get buddy up with your state crime lab, they have workshops constantly to teach law enforcement officers about forensics, but it's also really nice if we can all learn together and we're all speaking the same language. Mm-hmm. That's a way to get into forensics. The Institute, go ahead.
Sorry, more of a certificate versus a master's. It's a certificate or specialized training, not so much a master's program. Am I understanding that right?
So there's all different sorts of things to advance your forensic knowledge and advance in the specialty. You can get a master's or a doctorate diploma in forensics. You can get a certificate in sexual assault nurse examiner. There's certificate programs in strangulation. There's certificate programs in legal nurse consulting, forensic nurse and death investigator. There's just classes you can take and gain CEs on all of this forensic stuff. And you can buddy up with your state crime lab to get information on forensics. The other great resource out there is the Institute of Strangulation that is in California. They have a plethora of resources on their website. They offer CEs and they offer training as well.
Okay, that's great. Sayla asked, a clean gunshot wound through the entrance and an exit, no internal damage. Are they packed along the length of the track?
I'm not sure I understand the question. Is what passed along the length of the track? Evidence?
She's asking, is the wound packed from entrance to exit for healing purposes, is what I think I understand.
So it depends on where that bullet is passing through. What is the age of the person? Is there a lot of comorbidities? Like children, they heal up so quick, and I'm sure you've seen that in the PICU. Like tracheostomas in kids, you pop out their trach and their stoma's gone. You're like, what just happened? So kids are human bodies, and children have remarkable healing. So you could have an entrance and exit wound and not even be able to identify it by the time that they get to the hospital. It really there's so many factors that play in there.
Mm-hmm. Agreed.
But speaking specifically on the tract of the gunshot wound, so when you think about a bullet entering a body, you have a primary and secondary injury. So your primary injury is that tract. It's the tissue that bullet comes in contact with. And then you have what's called this shock wave that happens, and that's a secondary injury zone in ballistics. So that was really what that'll affect encapsulated organs, like your kidneys, that shock wave is, or even your liver or your spleen. So you want to think about not only the tissues that the bullet came in contact with, but also that secondary injury, and different ammunition, different bullets have different affect that in different ways. And in fact, there's ammunition or bullet profiles, and I'll post them in our group so you can get a look at some bullets have huge shock waves or secondary injury zone patterns. And so I'll post a couple pictures so you can see the difference.
Awesome. That's great. Tina asked, is there always a forensic nurse at the hospital, or is it an on-call type of position? You've kind of answered this, but she's asking, is it on-call where you have X number of minutes to arrive at the hospital to meet demand when called? I know different hospitals do it differently.
That's exactly right. Different hospitals do it differently. Some places don't even go to the hospital depending on the injury. Of course, gunshot wounds will go to the hospital, but some places, for domestic violence or child abuse or elder abuse, they have what's called family justice centers, and that is really best practice for something that's not a medical emergency. In that family justice center, they have the forensic nurse, they have law enforcement, they have a victim's advocate, they also have a prosecution there. So everything that victims need is in one place. And so that's great, but what's even greater is if I work with law enforcement every single day, right? We're a team. We speak the same language. We know each other. So, and I can advocate best for that officer. It becomes a team approach, and we know that's always better. And so that's one way a victim can get cared for. Another way is an on-call system. So if a victim, say, of sexual violence or even of a gunshot wound presents to the ER would call a forensic nurse in, and they, depending on where they work, they might have 30 minutes to an hour to get to the hospital to care for that patient. And in the meantime, if it's a sexual assault victim, usually the emergency nurse just gives them maybe a snack and a drink of water, and brings them to a private room where they wait, a private, safe room. We don't want to ever leave them in the lobby. Any victim on victim crime, we never want to leave in the lobby because the bad guy can come and get them there. We put them in a safe room until the nurse gets there. And some shops, not a lot of shops, but some shops do have forensic nurses or SANE nurses that are there 24/7.
So when I was at the a big hospital in a bigger city, well, we won't identify, we had a pediatric rape patient, and the SANE nurse and the detective were downstairs dealing with another crime. And so we waited and we waited, and it was so awful because we couldn't take her clothes off, or we couldn't do anything to this patient. And so we waited and we waited, and this was my very first experience with a situation like this. And then once the SANE nurse came in and her and the detective started taking pictures, I was like, oh my gosh, I could never do your role. And so of course I picked her brain like crazy after the whole thing was all said and done and we were all out there documenting. But I just don't know how you guys do it. Like, I mean, I see the role and the advocacy and the support and all of that aftermath stuff, how rewarding it could be. But man, what keeps you going?
Well, I love to learn, and forensics is a fast-growing specialty area, and there's always something to learn. And you're right, it's not rewarding. You're dealing with people on their worst day, and nothing is worse than a person-on-person child crime, especially child sexual assault, or even child physical abuse. I mean, those are some of your most horrible cases, and they do stay with you. But what keeps you going are those wins that you get when you put a bad guy away, and you know it's because you did the right stuff and you documented the right way, and you were able to be a fact witness and testify, and that keeps you going, knowing that you're doing the right thing even though it's tough. But with that said, just like any type of nursing right now, we're seeing a huge increase in burnout in nursing with everything that's going on. It's no different in forensic nursing, and you just have to do a lot of self-care.
Yeah, absolutely. I agree. And across the board, we all need to be normalizing the idea that it's okay for you to take a day. And there's nothing wrong with that. Breathe, take a day. It's okay, because we need you next week. And if you don't fill your tank today or tomorrow or whatever that looks like for you, you might not come back next week, and we need you. Whatever it looks like.
And that's so true of specifically, I think, ER nursing. It's a culture in ER nursing that I didn't get a break today. I didn't get a lunch today. I haven't peed today. And, I don't call in sick, and I stay after, and I work those 16-hour shifts. It used to be a sense of pride, or, like you got a sticker at the end of the day if you just beat up on yourself like that. And we have to change that culture, and we have to be supportive of each other. If somebody's had a rough time or a rough go, or we just had that child code or that child sexual assault come in, to tap you on the shoulder and say, hey, why don't you go take 15 in the break room? Why don't you go walk around the hospital for a couple laps and just get out of here? I'll take your patient assignment right now.
Yeah, amen to that. I think we all need to support each other in creating this culture change. Absolutely. So 2 more questions from Tina. She asked, do you only see living patients? And I think the answer to that is no, based on some descriptions that you gave previously. But what does the non-living look like?
So the non-living looks just like the non-living. Usually, it depends on the state that you live in. Based on if you have coroners, forensic pathologists, or a forensic nurse death investigator. Okay. So in most states, not most states, but in some states, the requirement to be a coroner is a high school diploma, and you get voted in. And so, right? And other states from there, the requirements are increased. So a bachelor's degree, some type of training in specifically forensic death investigation. So it really depends on the state you live in, what that looks like. In most high-profile cases or intense cases, those cases go to forensic pathologists. But there's not a whole lot of forensic pathologists in the United States. I think the last I checked was around 850 to 900 in the entire country. So we don't have a lot of those. So they really only take those high-profile cases. All the other cases go to coroners and forensic nurse death investigators. And that looks like determining, documenting, taking pictures, and determining the cause of death.
And are you working alongside the coroners at the morgue? Is that the role that you're playing?
So it could be that a forensic nurse death investigator is just the official term for a nurse coroner. So the coroner and forensic nurse death investigator is really just a coroner that's a nurse.
Gotcha.
So yes, it depends on what the setup is. Sometimes it could be the morgue, it could be a room. Some hospitals have the morgue in conjunction at their hospital. So it really just depends. There's some people that have them. I know one small city had theirs in somebody's home. Basically, it was an apartment building that the state or the town rented.
Wow, count me out on that one. So Gina wants to know what your biggest pet peeve is in your job. And I think what she's asking is, what is something that nursing could do better that would make your job easier, is the way I read into the question.
Well, I wish, I think one of the big things is not to interview the patient ahead of time. And just wait. It's hard to wait. Like you said, you gave that example of waiting with that child, but there are certain things that that can really kind of scare the victim or sway the victim in a different direction, or evidence can be lost. So just hang tight. And if you do live and blessed to live in a place or work in an organization that has a forensic team, just be patient with them and let them get there and do what they do best.
And if you have the opportunity to any nurse or student that's listening, if you can be in the room with your patient while all of this is going on, if your assignment allows, I learned so much when I would do that. I was just, my mind was always blown about the order in which you do things and the way in which they talk to your patient. It was just so enlightening, and maybe not even just the crime case, but in dealing with your patients who have gone through hard things. It doesn't have to be a crime, but if you think about it, all of our patients have had some sort of trauma that's brought them in, whether it's I had to call 911 or whatever it is. They're in our hospitals because of something that's probably a little bit traumatic to them personally. So yeah, hang out with your SANE and forensic nurses, because I learned so much. This is our closing question. I see no other questions coming through. Lots of people appreciating you and all of your knowledge, Gina.
Well, thank you.
It's for you.
I'm happy to be here.
Yeah, people saying, thank you for the information. Gina's amazing. You're amazing. So you can read through all those comments later. Okay, in closing, if every nurse or student was listening, took one thing away from our discussion today, what would it be?
I think that if you're in nursing, you're a patient advocate. Regardless of where you work, you're an oncology nurse, you're in the PICU, you're in the ER, you're in the ICU, you're a patient advocate. And that will help you become a better nurse. If you have the ability and you have the time, sign up to volunteer at your local victims advocacy center. Where, regardless of where you live, they're in need, and you are going to learn so much about victim services, and it will make you a better nurse.
I love that advice. Well, Gina, thank you so much for your time. I'm sorry that you were caught up late today at work, and I appreciate you giving us your time here today post-shift.
My pleasure, anytime. And I'll post those things in the comment box that I talked about during our lecture.
Awesome. I really look forward to it. Thank you so much, and I can't wait to learn from you again in the future.
All right, bye.